Hello, welcome to the total joint replacement class, your preoperative class before you have your total joint replacement. I'm Melissa O'Connor. I'm the nurse manager of 4 South, which is the unit you stay at after surgery. I'm going to review preoperative and postoperative care and expectations while you're here in the hospital. We have a physical therapist, Jill, who's going to go over your plan of care and your goals for PT here in the hospital, things you can do beforehand and things you can do after. And Gina is our case manager, and she's going to go over discharge planning and any medical equipment needs you might have. Little information about the hospital. We're Blue Cross Blue Shield, Blue Distinction Center for Joint Replacement, which just means that we have improved outcomes, lower readmission, and better quality for our patients. This part here, I have my friend Jill come up, because she's a physical therapist and she's very smart, and she will review the different joint replacement surgeries that we offer here.
Hello everyone, my name is Jill Phillips. I'm the physical therapist here at McLaren Port Huron. I've been here for 5 years. I've been a physical therapist for 17 years. I have observed several of the hip, knee, shoulder, and ankle replacement surgeries. I'm going to give you a couple of highlights of what's involved in the surgery. I have a couple models I'm just going to go over briefly with you and show you what's involved in your surgery. I'll start with the hip. Got a model here. The hip involves the femur bone and your pelvic bone. On the top of the femur, they cut the ball of the ball and socket joint off. They drill a hole down into your femur. They insert the stem and the new ball on. You can kind of see it goes down a few inches into your femur bone. On the pelvic bone, they have a plastic lining and a metal cup. That's usually affixed with about 3 or 4 screws, so that when they come together, you form your new ball and socket joint for your hip, and everything kind of goes together like that. They do have different sizes of all of these components so that I can make it as close to your natural anatomy as they can. Moving on to the shoulder, since it's very similar to the hip, you again have a ball and socket joint with a little shallower socket. On the head of your humerus bone here, they again take the ball off. They drill down into the bone. You have a nice stem and a new ball that goes in. You have a plastic socket on the corner of your scapula bone, and then that all comes together to form your new shoulder replacement. On a reverse total shoulder, if you know you're having a reverse total shoulder, they put the ball on the end of the scapula and then put this shallow socket on the end of your femur. So they essentially just reverse the components. That's usually if you've had a rotator cuff injury and have a bad rotator cuff. It just acts as better leverage if they do it that way. So you may have a traditional or a reverse. For the knee, I'll show you here. We're talking again about your femur bone, the lower end of your femur, and the tibia, which is the larger of the 2 bones in your lower leg. What they do with the knee surgery, they'll make their incision down the front. They sand the ends of the bone down to make them nice and flat. With arthritis, usually have some bumps, lumps, pitting. Everything is kind of rough, so they sand the edges down. There are 2 holes that they'll drill in, and then you have a peg, 2 pegs here on the new metal end that fits in like so. On the lower bone of the tibia, they also will sand that down. They make a little bit of a V or a wedge cut. They insert this metal plate with a plastic lining in between, and then that all comes together as your new knee joint. The third component of the knee, your kneecap or patella, and I'll show you on this model here. These are just tendons that attach your muscle to the bone. They take and they flip that so they can see your kneecap on the underside. If that has any bumps, lumps, or pitting, they will also sand that down and put a plastic button on the back of that. So that's the third part of the knee. I know some of you may be having an ankle replacement. It's hard to see on this model, but we're talking about the lower end of your tibia and then your talus bone or the talus bone in your ankle. So they also, just like with the knee, they will sand down the end of the tibia. There is a metal plate, and there are some slides that will be shown that makes this a little more clear. There's a metal plate there. And then on the end of the talus, they again screw down a little bit into there. There's a metal plate and a plastic lining, and it all fits together. So it's essentially just sanding the ends of the bone down, resurfacing them, and then having a plastic insert for your new cartilage replacement. And those are the components of the joint replacement surgeries. I'll have Melissa come back up. She's going to talk about incisions, and we'll move on from there.
So for each of the different surgeries, your incisions will evidently be in different spots. For your hip, most of the time now we're doing an anterior approach where your incision will be in the front. It's usually about 4 to 6 inches, and it's covered with glue. We close with glue now, and then a piece of, it's like surgical tape. It's kind of like if you've ever seen drywall tape, but a smaller sterile piece of tape that they put over top of the incision that comes off when you return for your follow-up appointment. The knees, we have big incisions down the middle of your knee that are also covered with the glue and the tape. After surgery, you'll have a big ACE wrap on from your thigh down to your ankle. That will take off the next morning and replace with a smaller dressing that just goes over top of your incision. Your shoulder usually hits your incisions somewhere in this area, and we have, that's usually closed with one long running stitch that the doctor puts on. Sometimes he puts glue and sometimes he puts steri strips. It's just their preference. And then with the ankle, you're going to come out with like it's what we call an OCL or a half cast, kind of a plaster cast, and then that's going to be wrapped with a whole bunch of gauze and padding and then wrapped with an ACE wrap. We used to use staples, but we haven't used those in probably over 6 years. If you're allergic to any of the glue or anything like that, we do, they will use the staples. This slide also goes over total shoulder replacements. With the shoulder, you will have a sling afterwards. Sometimes it will have a ball attached to it just so you can keep working on the motion, range of motion in your hand. And then anesthesia also may do what we call a interscalene block or a like nerve block that helps with your pain postoperatively. So when you are at home, you're going to be on a walker for a couple weeks at least. So there's a couple things we want you to do before you come into the hospital. You'll be on a walker if you're having a hip or knee or ankle surgery. So we want you to rearrange your furniture so you have a safe walk-through. You want to be able to get from your chair to the bedroom, to the bathroom, to the kitchen, and have enough room to get through with a walker. We like you to have a chair that is a steady, non-rocking chair, something that has arms because you're going to be using your arms a lot to get up and down from furniture. Jill will be going over some exercises you can do to strengthen your muscles before surgery. If you have any throw rugs, we suggest that you remove them from your home. Just because your foot's going to feel a little heavier than it did before surgery, so we want to make sure that it's not dragging and you don't trip and you don't have to come back and see us. If you are the cook in your house, you might want to make some easy pre-made meals or something that's in the microwave or that you can microwave, take out of the freezer and put in the microwave. If you have somebody to cook for you at home, that's great. You don't have to worry about it. There's something so you're not standing preparing meals for a long period of time. Any frequently used items that you use that you have to reach up high for or reach down low for, we like you to put at the counter space when you go home for the first couple of weeks, just until you're feeling a little more confident in your walking ability. Also, we like someone to stay with you at least the first couple nights when you get home, so you have somebody there to make sure that you're safe when you're getting up and down to the bathroom. Transportation for the first month, your surgeon will be the one who says when you can drive again. Usually it's about a month before they let you drive or be until you're off of your pain medication. Indoor-outdoor task, someone to help you if it's the summertime, cut the grass, or in the wintertime, shovel snow, just so you're not out there trying to do it yourself. And then pets, We say if you have a pet, whoever's driving you home, have them put them in another room. Have you come into the house, sit down, and then reintroduce your pet to you. One time we had a patient that went home and had a German Shepherd, and the dog ended up knocking him down as he was walking into the house. So they're going to be excited to see you. They haven't seen mom or dad in a while, and so that's what we suggest so you don't end up on the floor. So before surgery, we're going to do some things to prevent infection. Infection is a risk when you have any type of surgery. So one of the things your surgeon's going to ask you to get medical clearance from your primary care physician. Your surgeon should have given you a script for nasal swabbing of your nose. That is to look to see if you are colonized with MRSA bacteria. If you test positive for it, doesn't mean that you have it, just means that we're going to treat you with a different antibiotic. All of our skin and everything has bacteria that lives there normally. It's called our normal flora, and normally it's not harmful to us. But if we cut into our body, we don't want the bacteria from the outside getting into the inside. So we'll swab your nose. If you test positive, we'll have you come in a little earlier. We're going to treat you with a different antibiotic that takes longer to infuse. It's called vancomycin, and that will help prevent you from getting an infection. If you smoke, we ask you to stop smoking. When you smoke, it decreases the blood flow to your new joint, which would make your healing time longer, which could also put you more at risk for infection. If you're a diabetic, we like you to have well-controlled blood sugars, so you're not high and low all the time. That also helps with your healing. And then also, if you have come to the hospital to get one of these gift bags. It's not really a gift bag, but it's going to help you prevent infection. So we've got a couple things in there. There should be 3 of these sponges that have medication on it that help decrease the normal bacteria that's on your skin. And in the front of your folders, we also have a frequently asked question sheet that reviews information about surgical site infections. But on the back, there's instructions of how to use the sponges beforehand. So you're going to take a total of 3 showers. And we're going to start with, you're going to get in the shower, you're going to wash everything like you normally do, shampoo your hair, and then you're going to pull out one of these sponges and you're going to wash everywhere except for your face and your privates. And then you're going to do it 3 times before surgery, so you can do it 2 nights before, the night before, and the morning of, or you can do it the morning before, the night before, and the morning of surgery. And then once again, that's just to help decrease the amount of bacteria that's normally there on your skin. Also, in your bag, we have mouthwash. Same idea there. You have bacteria that's in there normally. We want to decrease the amount of that while you're having surgery. So this is just a swish and spit. And then you do that 2-3 times before surgery. Also in your gift, I keep calling it a gift bag, but your help you prevent infection bag, we can call it, there should be an incentive spirometer. Yours might look a little different than this one, and what this does is helps to increase our, make sure we're taking a deep breath and inflating all of our lungs that we can. So the bottom of our lungs aren't closed up and bacteria can make a little home and get what we call hospital-acquired pneumonia. So this is, there's a little, I don't know if you'll be able to see it, but there's a white piece here that you're going to take a deep breath and suck in, and you want to pull it up as high as you can at a controlled rate and hold it there at the top for a couple seconds and then let out your breath. So we'll ask you to do this after surgery 10 times an hour while you're awake. Don't do it 10 times in a row, because if you do that, you'll end up getting dizzy. I've done it before. So when you're watching TV, watch TV, and then when the commercial comes on, do it 2 or 3 times, then watch your program again, and then when the next commercial break comes on, do it 2 or 3 more times. Also, before you go to bed the night before surgery, clean pajamas and clean sheets. And also, best way to prevent disease and infection is to wash your hands. Oops. I also forgot to say that when you get to the hospital, we're going to wipe out the inside of your nose with iodine, which helps to decrease the bacteria that is in your nose normally. Also, another way for us to help prevent you from developing any infections. When you have surgery, you're also at risk for developing blood clots. So there's a couple things that we're going to do, a couple things you're going to do, and medication that we're going to have you go home on. One thing that you can do when you're laying in bed or you're in the chair, just move your feet up and down like you're pushing the gas and the brake on your car. And that just helps to bring the blood flow out of your legs back up into your heart and keep circulating through your body. So we like you to do that at least 10 times an hour while you're awake, but if you're just sitting there, you can just do it real quick. We also, depending on your surgeon and their preference, we'll have support hose, which are those really tight stockings that are usually white. Here in the hospital, you'll either have a knee high or a thigh high, and we'll help you put those on if you need help when you get here because they can be challenging. And also you might have what we call a sequential compression device, which is like a sleeve that wraps around your calves and it blows up with air. That also too just stimulates the blood moving back up into your heart. As far as medication, every doctor has a different preference, and they will order with what they feel is the best option. If you have already take some kind of blood thinner or anticoagulant, we will probably try to get you back onto that. But most of the time, most of our surgeons are using a low-dose aspirin twice a day. And then sometimes they use Xarelto, which is an expensive medication. So we do work with our case management department to help to make sure that that will be affordable for you. And if not, we will switch you to an option that is more affordable. So before surgery, a pre-admission testing nurse is going to call you. She's going to ask you about all the medications that you take, your allergies, your medical history, and your surgical history. If you take a lot of medications or you have a lot of allergies, I suggest writing them down on a piece of paper and bringing them with you when you come to surgery, just so you're not trying to remember everything that you are allergic to or every medication that you take. This is a registered nurse, so if you have any questions, she will be able to answer them for you. If she doesn't know the answer, she will find out what the answer is and call you back. She's also going to provide you with instructions. While you're here in the hospital, you can always wear our fancy hospital gowns, but if you want to feel a little more comfortable, you can bring your own clothing and we'll help you get changed into it. We suggest that you bring loose-fitting clothing, something that's easy for if you have a hip incision, so we can pull down to look at your incision, or if it's long, something that's loose enough that we can pull up and look at your knee incision or your ankle. Shoulders, we suggest that you have a button-up shirt. It's usually easier for us to get that on you and easier for you to be able to get on and off. If you want to bring a nightgown or a robe, we suggest that it's not any longer than knee length, just because sometimes when you're getting in and out of bed, your feet will get caught in it, and we don't want you to fall while you're here in the hospital. If you have any shoes that you'd like to practice walking in while you're here, something that fits your foot a little looser now, because after surgery your foot might be swollen, so something that's looser that has a good sole to help you practice walking in. Flip-flops are not an example of something good, so like a Croc would be good if you have Crocs, or a slip-on shoe that has a hard sole. If you have sleep apnea, please bring your CPAP here to the hospital so you can sleep more comfortably that night. We have sterile water here, so you don't have to lug a big gallon of water in here. We have that here and we'll help get that set up. If you have anything you want to do to pass the time, like your cell phone or a laptop, anything like that, feel free to bring it. Anything that's valuable to you, though, we suggest you, like jewelry or anything like that, we would like you to keep at home so it doesn't get lost here in transit. Day of surgery, you're going to come into through our main Wismar entrance, and you're going to bring your photo ID and your insurance cards. Usually we ask you to come about an hour and a half before surgery, and then you check in at the main desk, and they're going to direct you to go up to the second floor balcony. You'll wait there, and then they'll come out and get you for surgery, take you back, get your IV started, get you all prepped. Then we'll let your family come back and sit with you, and then they can sit with you right until the point where they wheel you back to surgery. When you're back there, the anesthesiologist is going to come. He's going to review all the questions that the PAT nurse asked you, your allergies, your medications, your medical history, surgical history, and he'll discuss any concerns that you have there. Also, while you're back there, your surgeon and or the PA will come back and see you before surgery. So anesthesia options, we have a couple different ones. Usually we use a spinal, which is good, and it helps control your pain after surgery because we're going to be getting you up sooner after surgery than before. If you are going home same day as surgery, we do a general anesthetic that usually wears off a little quicker than our spinal. Also, for pain control, we use the surgeon, before he closes up the incision, will inject a local anesthesia or analgesic into your operative site to help control with pain because it'll last a little longer. If you're a total knee patient, we have what we call an on-cue ball, which this medication is full of, usually when you see this, it'll be blown up full, about the size of a blooper ball, I'd say. And it goes right along one of the nerves in your leg, in your thigh here. It'll be put in by the anesthesiologist. The medication that's in here is ropivacaine, which is kind of in the family of like when you go to the dentist and they numb your mouth, same family. So it can last up to 3 days. There's a dial there that you can control if you think you need more of it or if you need less of it. And usually that lasts about 3 days post-op. We also have one of our surgeons does iovera injections, which is cold therapy to the nerve, kind of blocks it, numbs it up a little bit before surgery. That can last sometimes before surgery and after surgery. So those are a couple of options we do for anesthesia. Before surgery, you're with your family until they wheel you back to surgery. Usually surgery is about 2 hours. This depends on how everything's going in there. Recovery room time's about 1 to 2 hours. After the surgeon's done, he'll come out and meet with your family, tell them how everything went. And then after you're in recovery and they're sending you to the floor to stay, transport staff will come out to the waiting room to where you are and will tell you what room you're in and give you directions on how to get there. This is a picture of some of our surgical team. Most of the time you don't remember them, but there they are. They're lovely people. And then this is some of the staff on 4 South. Usually we have people staying about 1 night. Usually the next day you go home. So you're not with us very long. So hospital stay. Physical therapy, when I first started nursing, we really didn't get people out of bed until the next morning, but now we've found that the sooner we get people out of bed, the better they do. So within 2 hours-ish of getting back to the floor, we try to get you up and get you moving. Usually it's when you have to go to the bathroom for the first time, is when we'll get you up and get you moving. And then after that, you see, if an early morning surgery, Jill will come and see you. If you have a later afternoon surgery, one of the staff from 4 South will get you up and get you moving. For our knee patients, some of our knee patients have a CPM, which stands for continuous passive motion. It's something that we put, it lays in the bed and kind of just bends your knee passively for you, just to work on your extension. Not all surgeons use that, your extension and flexion. Not all surgeons use that, and sometimes your insurance doesn't always have that in your bundle. So that is up to your surgeon's discretion if he uses it or not. Usually when you get back to the floor too, we start you on clear liquids, give you a little water or something, make sure you tolerate that and you're not nauseated. And then we will move you to regular food, usually by the end of the day. Bathroom, so we are moving away from using catheters, urinary catheters, because when you have one in, it puts you at risk for infection, and that infection could actually go to your surgical site. So we are not using catheters very much anymore across the board. So we will always want you to call us when you have to get up to go to the bathroom, unless physical therapy, Jill has given you the green light to get up by yourself. Last thing I'm going to talk about before I let Jill come up here is pain management. So when you come in, we're going to have you rate your pain on a scale of 0 to 10. In the booklet on page 5, there's actually this scale with the smiley faces. And this has, we're going to set a goal with you when you come in. You're going to have surgery, so you're going to have pain. We're not going to be able to take your pain all the way away, but our goal is for your pain to be manageable so you can get up and work with physical therapy or get up and go to the bathroom. The best way to stay on top of your pain is not to wait till it's out of control to let us know. Medications are scheduled as needed. There's nothing that has a set schedule that we give to you routinely. We do check with you frequently to see how your pain's doing, but you letting us know helps us be able to give you the right medications to help control your pain. We also say take medications before painful activities, which we say Jill's painful, but she's really not. I never see anybody crying in the hall with her when she's walking with them. And then the last thing about pain medication, the biggest side effect that we have with pain medication is constipation. So you'll go home on some stool softeners. You can buy them over the counter ahead of time if you'd like, or the doctor sometimes will write you a script for them, but you can buy them over the counter afterwards either. So drink lots of water, high fiber diet, and take your stool softeners while you're taking your pain medication because you don't want to have the problem of constipation and have to come back and see us for that.
Again, my name is Jill Phillips. I'll be likely one of the physical therapists that you'll see when you're here. I'm going to start by talking about the physical therapy for the ankle and the shoulder before I get into the hip and the knee. If you're having a total shoulder replacement and you're someone who uses a walker right now to get around, which you need 2 hands on, that will be a problem after your total shoulder replacement. You won't be allowed to bear weight on the surgical side. So if you're someone that typically uses a walker and now you won't be able to, I will sometimes get ordered to assess your gait, see how you're walking, if you can use a cane, or if you can use just a handhold assist or assist from someone at home. Typically, I don't get ordered to do anything specifically with your shoulder unless the doctor asks us to see you. If you're someone who normally gets around independently, your nursing staff will help you up, get you around. With the shoulder patients, I do ask that you do hand pumps. And again, as Melissa mentioned earlier, sometimes your sling that you have on will have a ball attached to it that you can squeeze, again, to help prevent swelling in your hands and to encourage blood flow. For your ankle replacement, typically I would see you the day after surgery. If you need to use a bathroom the day of surgery, your nursing staff can help you to a commode, so you don't have to use a bedpan or anything like that. But typically I would see the ankle replacements the day after surgery. I'll bring in a walker, we'll have you get up at the very least, show you how to hop safely to get to a chair. Typically you are not allowed to bear weight on your ankle for about 6 to 8 weeks. And again, this is all just general information. Your surgeon will let you know specifically how long your weight-bearing restrictions are. But our goal is to teach you how to get in and out of bed, up and down from the bed, the chair, the toilet safely, making sure you're able to be mobile and to get into your house safely. So you'll see me the day after surgery and once daily thereafter until you're discharged. For our hip and knee patients, if you know you are going home the same day or having outpatient surgery, I actually come to you in the recovery area. So your physical therapy is just a little accelerated because you'd be going home the same day. Usually the recovery nurse will call me when you're ready to get up, when you're feeling okay, you're not nauseated, you're able to move your leg around okay, and a lot of times when you have to go to the bathroom. But I will come down. They have walkers down in the recovery area. They also have a set of stairs that we're able to practice. I'll go over some exercises with you. I'll teach you how to get in and out of bed, how to stand up safely, how to walk with the walker safely, and we have the set of stairs down there that I'll walk you to, have you make sure you can go up and down stairs safely. So we'll cover a lot in a short amount of time, but making sure that you're safe to go home that same day. So if you're having an outpatient surgery, I will come to you when your recovery nurse says you're ready to go. If you're a regular hip and knee, that's going to stay overnight with us. Again, as Melissa said, if you have an early morning surgery and you're up and into a room on our surgical floor on 4 South around lunchtime or shortly thereafter, I stay a little bit later on Mondays and Tuesdays, our heavier volume surgery days, and I'm able to get to you usually around 1:30 in the afternoon after lunch. Again, a lot of times your nurse will call me telling me you're ready to get up to the bathroom, and I'll come in. I bring a walker with me. I bring this piece of equipment here. It's called a leg lifter. This will help you to get your leg in and out of bed. We'll show you how to use it when you're here. This loop goes around your foot on that surgical side, so you're in control and can help manipulate your leg in and out of bed. We'll sit up at the edge of the bed if you're not feeling nauseated, you're not dizzy. We stand. I can walk you into the bathroom. I can get you to a reclining chair that we have in each of our private rooms. We have a nice reclining chair next to the bed. Or several people I've been able to actually get up and walk into the hallway. Everybody comes out of anesthesia a little differently. So whatever you are feeling you're capable of and can tolerate, we will do that day. We very much go with the flow. It is not uncommon when I come in for that spinal not to be fully worn off. So sometimes you'll be moving it okay, but when we go to stand, it'll still feel a little numb or weak, and sometimes you'll have a little hiccup like this. I call it a jello leg, where you don't have that full control. If that's the case and we're not ready to walk safely because you don't have that control in your leg, we are able to bring in a bedside commode and at the very least get you onto the bedside commode to be able to use the bathroom or help you stand and step or pivot to a chair. And again, that usually will wear off in a matter of hours. In the evening, usually by dinner time, most of that numbness has worn away. But we will make sure you're safe and do what we can that same day of surgery. If I don't get to you, you have a later surgery that day. Your nursing staff is well qualified. They've been trained to help you. They can help you sit up, get to the bathroom, get to the chair, and walk a little bit as well. The next morning after surgery, I will come usually sometime after breakfast. I'll come into your room. I'll ask you about your house. Do you have 1 or 2 floors? Do you have stairs to get into the house or up to a bedroom? So that I can make sure we practice everything we need to do to get home safely. Again, if you haven't been up already, we'll bring in a walker for you. We will get you up, walk in the hallway, do stairs if you have stairs to get into your home. And a lot of times, if you do well that morning, we get up and down, you're moving around safely, you're able to manage the stairs, and the medical doctor and the surgeon have cleared you, and you've done well with therapy. Sometimes you can go home that next day after surgery in the afternoon. If you're someone who's having issues with pain control, or you're not doing as well with therapy right away, you need a little bit more physical assistance, or you're a little wobbly when you get up or dizzy or anything like that, and you need to stay an additional night, that's fine. We will get you up usually again that afternoon. I'll come twice then, and we'll see how you're doing. We'll progress you slowly as we can. And then the following day, if you stay another night, it's the same routine. I come once in the morning. If you're not discharged home, I usually try to see you again for a second time that day. We also have occupational therapists that are here. That again depends on if you'll get occupational therapy depending on what your needs are. Most of our surgeons who do total hips do the anterior approach. With the anterior approach, you do not have any positional or movement restrictions. You may have heard of people having hip precautions or hip dislocation precautions. With the anterior approach, they spread your muscles so they don't have to physically cut them. What that does is allows them to return to their normal tension, and they help to hold your ball and socket joint in place, reducing the risk for dislocation. We do have one physician who does do a posterior hip. In that case, your incision is more on the side or towards the back in your buttock area. With that surgery, they do have to cut the muscles on the side of the hip, so you are at a little bit increased risk for dislocation. So if you know you're someone who's having a posterior hip, you will have precautions to follow, which include not crossing the surgery leg over the other side, not bending over past a 90-degree angle with your thigh and your trunk, and then not having your feet rotate inward. This will all be in the booklets that you would get. There's information on this. Again, anterior hips, you have no positional or movement restrictions. Posterior hips, you have those 3 precautions to follow for just a couple of weeks or months after surgery. So if you're someone who's having a posterior hip or someone who's having issues getting on and off the toilet, having trouble getting dressed, reaching down to your feet, or bringing your feet up to you. We can usually get occupational therapy ordered. They address those self-care, we call them activities of daily living, or ADLs, how you're getting on and off the toilet, how you're dealing with your personal hygiene, getting dressed. So PT and OT overlap in a lot of areas, but we will make sure you have me for sure, and then OT if needed, if you need that. Also in the booklets that you'll get, there are exercises that you can do. Melissa mentioned ankle pumps. Those are good to help prevent blood clots. You just move your ankles up and down like you're stepping on the gas. I'm going to come forward to the chair and show you a couple other things here. So the ankle pumps, you're just moving your feet up and down. You can also, when you're sitting in the chair, kick your legs out straight. You can do seated marches. One I like to highlight a lot is a chair push-up. Find a chair with armrests at home. Get to the edge of it like you're about to get up, and then just practice lifting your body weight up and down. You're going to be using your arms a lot to push while your one leg is hurting. If you're having your shoulder, though, you can't use one arm, so practice pushing yourself up with your good arm and getting up and down one-handed. You won't be, again, allowed to bear weight on your shoulder if you're having a total shoulder. There are also standing exercises you can do. If you need something to hold on to for balance, please do walker, counter. You can move your leg out to the side. We call that hip abduction, or moving away from the body. You can do kicks forward. You can do butt kicks, as we call them, bending your knee behind you, marching in place. Again, there's a lot of exercises in a lot of our materials that you can go over. I'm going to move back here. You can do them either for, it'll say total hip or total knee. It doesn't matter what you're having. You can do either of those exercises. Ankle, obviously you can do all of them except for any ones involving your ankle on that surgery side. And one of the slides here, it shows some special equipment that may make things easier, like getting dressed, getting shoes and socks on. I believe in the picture, there's a long-handled shoehorn, a long-handled sponge, elastic shoelaces. Another couple things that are highlighted are a reacher. These are good for, again, picking something off the floor if you're having a hard time bending over. This is good to help get pants started, acts as an extension of your arm. You get a hold of the pant leg or your underwear, pull that over until you can reach it easily with your hands and pull that up. Another piece of equipment that is helpful, whether you're having a hip or a knee. Everybody likes this. This is a sock aid. It's just a half molded piece of plastic. If you're having trouble, again, bending down to reach your feet or bringing your feet up to you, these are our hospital socks that you'll get. They have grippies on both sides. What you do with this, I'll have a seat because we'll show you this seated. You pull the sock on up to the ropes so the toes are flat against there. And again, this is to help so you don't have to bend over. I'm going to take my shoe off, but you'll throw it on the floor in front of you. You'll put your foot in and pull up on the ropes, and then you got your sock on, and I didn't have to bend over to do it. So these things are not typically covered by insurance. They are something that you can go ahead and look for and purchase ahead of time. Amazon has these things. Walgreens, Walmart, any of your local pharmacies, or Meijer even has some of these things. We just introduce them to you now so you have an opportunity to maybe ask a friend if they have anything, or you can go out and purchase them yourselves because, again, they aren't typically covered by insurance. The last couple of things I'm going to talk about, walkers. Most of our hips and most of our knees are allowed to bear their full weight as tolerated. The ankle replacements, you will be non-weight bearing for a period of time. So most of you will need a walker to start out with. If you have a walker at home, that's great. You don't have to bring it in unless, of course, you need it to get here safely and comfortably. We just ask that you put your name on it somewhere, either with permanent marker or address label. That's fine. If you are borrowing a walker from a friend, family member, that's great too, but I do ask that you bring that in so we can make sure it's sized properly for you. At home, if you want to check this yourself, take your walker that you have that you may be borrowing, set it up, stand in it with your arms down at your sides. The grips should hit you at about the level of your wrist. That way when you do grab it, you have a slight bend in your elbow. You're not up here chicken winged, as I call it, and you're not fully extended and bent over. I had a gentleman who was about 6'3". He borrowed his mother-in-law's walker, who was about my height, 5 foot nothing, and he was standing walking around like this. So we don't want that. There are ranges of sizes of the walkers. We have some shorter ones. There are wider ones that have a larger weight capacity or width, and there are taller ones. So if you're borrowing one, have someone bring that in the morning after surgery, or if you're having an outpatient surgery, same day discharge, bring that in with you and we'll make sure we have it sized properly for you. It is okay to have a regular or standard walker without wheels. It's okay to use walkers with 2 wheels in the front. It is also okay to use walkers that have the 4 wheels and the brakes. We will test drive whatever you want to try to use. As long as you're safe getting around with it, it's fine. I will say one word about the 4-wheeled walkers. They are, because the front wheels pivot, they are a little bit more mobile. So if you're someone who's really putting a lot of weight through the walker and it wiggles and causes you to be a little unbalanced, sometimes that's just something you got to take caution with. And again, we'll practice with you and make sure you have the proper walker for home that you're going to be safe with. I have had people ask, is it okay to use crutches? Yes, again, I will test drive whatever you want to try to work with, and as long as you're safe with it and can get around with it okay, that's fine. How long you use the walker is typically up to you. For those of you who do not have any weight-bearing restriction, it's okay to move from it whenever you are ready. I tell people this, you use your walker as long as you need to be, number 1, safe when you're up, number 2, to be comfortable when you're using it, and to be confident when you're up and walking. A lot of times it happens by accident. You'll be at home, usually in the kitchen. You'll be seated at the table. You forgot to go get something out of the cupboard. You'll walk over to get it, and you've left your walker behind. That's okay. It probably means you're ready to move from it. The nice thing is that home therapy, when they come out and see you, they can work with you on transitioning from using the walker to either a cane or from the walker to nothing. But we'll go over all those things when you're here. I'll ask you what you have and what you might need at home, and we'll practice with whatever you need. If you're a total shoulder and you're getting around fine without anything, that's great. Again, if you're a total shoulder who is using a walker prior to, you won't be able to right after surgery while you're non-weight bearing on that surgery side. So we may have to use a cane, or there are other things we can use. So practice if at home doing things one-handed if you're a shoulder, or getting around without holding on to a walker if you need to. But we will practice those things when you're here. The last thing, car transfers. People will ask, how do I get in and out of the car? Usually when I'm talking to you, when I see you that first time, I'll ask you what kind of car you might be able to go home in. If you have an option of a higher car, minivan, truck, SUV, that's usually preferable. We'll have you step up on the running board to get to the seat, and then you swing your legs in one at a time from there. If you have a lower car, that's fine too. We just usually ask that you put an extra pillow or a folded up blanket to give you a little bit more height for when you go to get out at home. It is okay to have either, but it's usually typically easier to get up into, even if you have to boost up a little bit, and then to get out of the car. You'll swing your legs around to the side, have the walker in front of you, and then slide out safely if you're in a higher car. Again, it's always a little harder to get up from a lower surface, but if that's all you have, a lower car, again, if someone can just throw an extra pillow, blanket, or something padded so you have a little height on the way out, that's great. The last thing that patients have told us that have helped, tips over the years, is using a plastic bag on that front seat. Because then when you sit down, it's a little easier to swivel your legs in and out. You don't get stuck. If you have leather seats, you'll probably be okay. But we will talk through all of this when you're here and make sure we practice everything you need to and discuss everything you need to be safe at home. The next person that's going to come up and talk is Gina, one of our case manager. She's going to talk about any equipment needs and ordering, setting up your next level of care with therapy, and transitioning to a safe discharge home.
Hi, I'm Gina Stager, and I'm one of the nurse case managers here at McLaren Port Huron. I'm going to be helping you with your discharge planning, so that way when you leave the hospital here, the transition goes smooth and you have everything you need in a safe discharge plan. As far as length of stay, plan to stay overnight like the slide says. Some people go home the same day, some people end up staying more than one night, and that's okay. We want to make sure that your pain's under control and that you have everything you need before you go home, but typically you're going to stay overnight. One of the main things that case managers do is we check your insurance coverage to make sure, or to set up all the equipment needs that you have for at home. So like Jill had talked about earlier, a walker is very important once you get home, so we want to make sure you have that. If you don't have a means of getting one ahead of time, it's not a problem for us to get you one here at the hospital. We have a medical equipment place right here. We'll get a script from the doctor. They'll bring it right up to the bedside to you. There are sometimes costs associated with that. It just depends on your insurance. So if you have deductibles or co-pays, you're still going to be responsible for those, but we can get you that. Another piece of equipment that we often set up is the CPM, or continuous passive motion machine, for some of the knee patients. Not everybody uses a CPM anymore, so it'll be up to your surgeon, your insurance, and also your preference if you want one or not. But if that's something that you're going to use when you leave the hospital, we will set that up for you as well. The difference with that is that they're going to deliver that to your home and not to the bedside. It's big and bulky. You keep it 21 days, and then the home or the DME company is going to pick it up from your house for you, so you never have to transport it. Other equipment that you see up here, or anything for the bathroom, like commode chairs or shower chairs, toilet risers, those are not things that are covered by your insurance. So we recommend that if those are things that you're going to want to have, that you get those ahead of time. Some great places to look for those would be the United Way. They have a equipment closet that they'll lend out equipment to you. Also, Council on Aging has things that they sometimes can let you have. Local churches, fire departments, even Habitat for Humanity often has equipment that they'll let you have, so or pay a very small fee for. So you can also purchase them brand new off of Amazon.com. You can get them from Walmart, CVS, any pharmacy, Meijer, places like that. So that's what we recommend you do ahead of time if those are things that you're going to want to need or want to have. Of course, the next slide says you can borrow equipment from your friends or family. Like Jill said, though, if you're borrowing a walker, we want you to bring it in so we can make sure that's sized for you. So there's that. Now, as far as leaving the hospital, most people either go home with home care, or you're going to go to a rehab facility. Those are the two main paths we take when we leave. We're going to talk about home care first. There are lists of home care agencies in these packets, so if you pick this up from the hospital ahead of time, you can see that. You can also go to cms.gov, type in Home Health Compare, and then it'll allow you to pick your zip code, and it kind of gives you ratings of different home care agencies in your area. So we'd like you to have an idea ahead of time of what home care agency you want to use. We're not allowed to pick it for you. There's a lot of great agencies out there, and we don't want to be biased. But if you have no idea when you get here, we do have lists with those star ratings on it too, and we can help you narrow it down to a good company. What to expect with home care is that you're going to have a nurse that comes out once a week for about an hour just to assess that you're doing well, that you're not having any signs of infection, no signs of blood clots and things like that. They can change dressings and whatnot. And then you're going to have a physical therapist that comes out 3 times a week for an hour at a time to work with you. You're going to do that for about 2 weeks after you first get home from the hospital, and then you'll go to a follow-up appointment with your surgeon. Or they will let you know at that time if you're ready for outpatient therapy, which most people are. They're going to give you a script at the office, and then you just call someplace probably close to home that does outpatient therapy, make an appointment, and make sure they take your insurance. So that's about it for home care. And we'll talk about rehab. It's kind of along the same lines as the home care. We're not allowed to be biased. So there are lists in your folders as well for different rehab facilities in in your areas. And there's also, if you went to the CMS.gov website, you can also search for different rehab facilities in your area there. But the most important thing with rehab, you have to remember, it's up to your insurance company on whether you get to go to rehab or not. You have to have a scalable need for rehab to be appropriate for you. So I would caution everybody to kind of have a backup plan in case you're denied to go to rehab. It is 100% up to your insurance company whether you get to go to rehab or not. So we send them physical therapy notes and occupational therapy notes, and then they make a determination whether you qualify to go to rehab. So maybe have a backup plan of staying with a family member, having a family member or friend stay with you for a little bit, just in case you're denied for rehab. So. All right, and then also, if you do live home alone and you feel safe to go home, we'll allow you to do that. We can't stop you, but we do recommend that you have a designated helper, maybe a neighbor or a friend or family member that you could call and they can come help you with anything that you might need. So that way you have a safety plan in place. Alrighty, I think that's pretty much it for discharge planning, and we look forward to seeing you here at the hospital. And now I'm going to turn it back over to Melissa.
Frequently asked questions that we get are, will I set off metal detectors with my new knee? You may, so you want to allow some extra time for travel. Will I still be able to have an MRI? More than likely you'll be able to have an MRI, but you'll need to let the staff know at the MRI center that you've had a total joint replacement so they can do a little more research to see, to make sure that you are able to have the MRI. Will I still be able to have joint replacement surgery if I have a metal allergy? More than likely you will be able to, but you need to let your surgeon know right away so that he can get any additional allergy testing that might be needed. Tips for help after discharge: keep all of your follow-up appointments, especially your one with your orthopedic surgeon. Follow up with your primary care physician within a week. Call your surgeon or primary care physician if you have any questions 24 hours a day. After the office is closed, there's an answering service that will contact your surgeon, and they will be able to help get the surgeon to call you back if needed. Use your walker when you're ambulating until your physical therapist tells you that you're okay and safe to walk by yourself. Continue your physical therapy once you get home. Take your medications as directed. Things that we don't want you to do: we don't want you to sit in the bathtub to bathe. You won't be able to submerge your incision, but you will be able to take a shower. Don't overdo your activities. We want you to be doing your physical therapy, but there is such a thing as too much. Don't drive until your surgeon tells you that it's okay to drive. And then we also don't want you to use a pillow under your knee. When you put a pillow under your knee, you don't have full extension, which can cause some swelling in there and make it so you won't be able to straighten your leg all the way out. In summary, the main person involved in your recovery is you. Your hospital length of stay is usually overnight. Your pain's manageable and it's expected, so let us know how you're feeling so that we can medicate you appropriately. When we encourage activities to help you recover, sleep in the hospital can be minimal. We do have headphones and eye mask and earplugs if you do want any of those. You can also ask us to shut your door at night if you'd like. All of our rooms are private now, so you won't have to worry about having a roommate. You can call the kitchen to order a meal. Notify them if you have any allergies or if you're vegetarian or you need gluten-free so they can prepare your food properly. And then infections preventable, so limit your contact with sick family members. Have them call you or send you an email rather than come and see you so you don't get sick after surgery. And then anybody who's touching your incision or around your incision should be washing their hands, and don't let your pet come into contact with your incision. One thing also that I forgot to touch about earlier, but I will go over now, is we do have these bracelets that we'll be sending you home with. And in this folder here, we have information about them. They have your surgeons. We have them for both of our orthopedic groups, both Advanced Orthopedics and Orthopedic Associates, that have the phone number on there that we have you wear after surgery for 30 days, just so it's a helpful reminder for you to remember to call your surgeon's office before you would go to seek any medical attention related to your surgery. All right, that's it. We look forward to seeing you soon. Hopefully this was helpful to you, and thank you for choosing McLaren Port Huron.